Heather, can you hear, Jenny, can you hear me?
And we are about to start.
Yes, we are. Thank you.
For the small little technical issues. I'm Jenny Millsap. I'm going to be the moderator of the session. And our session is titled Substance Abuse Prevention and Best Practices. And this session is from 10:30 to 12:30. So if you found yourself in the wrong session, just please click sessions on, I believe it's the left-hand side of the little toolbar, and you can navigate into the correct session that you need to attend. And the CEUs pending for this session are LPCs, school psychologists, and social workers. And for those CEUs, after the conference, a link will be emailed to you for an online evaluation. The evaluation must be completed for each of the qualifying sessions within 2 weeks of the date that you're emailed that link. And then after completing the evaluation, the CEU certificate will be available for download. And then if you need any more information about that, you can visit the reception area of this event. And in order to ask questions, I know some of you guys are already using the chat feature on the right, so that's great. And then there's actually a Q&A session under the fourth little area, and it's called Q&A, and you can ask those questions there, and then I will try and relay the questions to Joanne. And so now, our presenter. Her name is Joanne McNeamer, MSPFII. She is with the Partnership for Success and the project director through the West Virginia Bureau for Behavioral Health. Like I said, she serves as the project director, and this is of the Strategic Prevention Framework Partnership for Success grant, which is federally funded through the grant through the Substance Abuse and Mental Health Services Administration. The West Virginia Department of Health and Human Resources Behavioral Health is the administrator of this grant, and the purpose of this grant program is to address 3 substance abuse prevention priorities: underage drinking, marijuana use, and IV drug use among high-risk youth between the ages of 9 and 20. So this program extends current established cross-agency and community-level partnerships by connecting substance abuse prevention programming to departments of social services and their community service providers. This includes working with populations disproportionately impacted by the consequences of substance abuse, i.e. children entering foster care systems, transition individuals that support persons with substance abuse issues, for example, women, families, parents, caregivers, and young adults. So without further ado, Miss Joanne, and I will share my screen for her presentation. Just 1 second.
Good morning. I am Joanne McNeamer, and I am here to share about prevention. And any day I get to share about prevention, it's a good day. So today we're going to have an overview of substance abuse prevention and best practice. And this is simply an overview. If you have questions or if you want to know about anything more in depth, please don't hesitate to contact me. And I already see we have joining of us some other of my peers that have expertise in this field as well. So anytime anybody wants to add in, please put in the chat and we will discuss whatever's on your mind at that time. I would like to start out by asking is what your background is. So if you could type in the chat what you believe your background is, I'll get a better idea of who we have in the audience today. Okay. That being said, we'll go ahead with the PowerPoint, and Jenny is going to help me with that. So Jenny, if you could move to the next screen, please. Thank you. Well, we start out with the obvious, which basically is what is prevention? And the term that describes it best is the action of stopping something from happening or arising. Now with SAMHSA, which is Substance Abuse Mental Health Systems, services tells us that prevention and early intervention strategies do reduce the impact of mental and substance use disorders in our communities. And you have a very good website to refer to if you'd like to get more information on prevention. Thank you. With our prevention efforts in West Virginia, we have various sectors. We have prevention lead organizations, of which there are 6. At the end of this slide, you'll have your contact information. We have the block grant, which is universal in general prevention. We have Partnerships for Success, which is administered through the prevention leads, but we have 15 coordinators that help us with that effort, and that works with at-risk youth. We have SINAR, which are your tobacco checks, suicide prevention, expanded school mental health, regional youth service centers, and other West Virginia prevention resources. So you can see we have various levels and various types of prevention efforts throughout our state. The infrastructure for prevention in West Virginia, as I mentioned, we have 6 regional prevention lead organizations. We refer to them as the PLOs. We have county coalitions. Each county should have a coalition, and you get that information through your prevention lead organizations. Currently 16 Partnerships for Success coordinators. We work with what is called the SOAR grant, which is the State Opioid Response. We have Adult Suicide Intervention Specialist. We work through Garrett Lee Smith Suicide Intervention Specialist with Prevent Suicide West Virginia. There's expanded school-based mental health, and we work through the Strategic Prevention Framework for Prescription Drugs. One of the most important things that we have added in prevention is through our promotion. And when people think of prevention, they're not quite sure what we're wanting to prevent. Well, we have added 8 dimensions of wellness to include overall mental and physical health. And as you look through the dimensions of wellness, you can see they're on various sectors: emotional, financial, social, spiritual, occupational, physical, intellectual, and environmental. And with anything else, you can see so often you might be strong perhaps in your emotional, but you're lacking in your spiritual. And prevention in West Virginia and through wellness, we try to have all those within balance. Now, there are some key definitions when we talk about prevention. We work with protective factors, which decrease the likelihood of substances, prevention practices, prevention programs, which are our predetermined, structured, coordinated set of activities, risk factors, which increase the likelihood of starting substance use, and substance misuse. And thank you for letting me know who's in this particular workshop. And again, I see varied backgrounds. I see counselors, I see school counselors, I see teachers, recovery coaches, I see people who are expertise in the field of prevention. If you could, to make this a little more interactive, could you maybe list something that you think is a protective factor with the focus that you work in? What do you see as protective factors? Just maybe one. Any ideas on what you think a protective factor might be? I can kind of give you some background on that. Your protective factors directly decrease the likelihood of substance use and behavioral health problems, or might help to impact the risk factors on behavioral health. Some kind of protective factors, basically, as we have here, very good answers: after school activities, family support, and we have those on different sectors. Family units, yes, all very good. We also know that one caring adult in a child's life can help with resiliency. You know, so many studies have been done in families where there are different risk factors, and you might have, say, a brother and a sister, and they both come from the same environment with the family, but the sister might have a caring adult in her life at school, so maybe as a teacher. And even though she has the same issues at home with what might be going on, that particular adult has played a role with providing resiliency for her. Well, you've given some good ideas with protective factors. What are some things that you all are experiencing as a risk factor? If you just want to type one in, please. What are some risk factors you see in your practice? Peer pressure. Thank you, Tim. Good answer. And Tim works on a college level. So, Tim, it sounds like even with college students, there might be some peer pressure. Nothing to do. Yes, Jennifer, ACE is a very good example so far. And we know, as with anything else, because we talk about balance, if you have a risk factor, the hope is that you can balance that out with a protective factor. Thank you. All very good answers. When we talk about substance misuse, that's the risky use of substance, maybe even without addiction, but it can include excessive behaviors. Heavy alcohol and tobacco use, prescription drug misuse. With misuse, that means that you are misusing a substance such as an opioid that's to help you get better, something that was intended to help you as a prescription, but you're misusing it. You're not taking it out as the doctor asked you to. If you're abusing it, it may not be your particular prescription. We talk about youth perceptions. Basically, those are the attitudes and beliefs that young adults have about substance misuse, and they've changed over time. When I started doing prevention many years ago, we were actually doing scare tactics like maybe the Grim Reaper, the mock car crashes. We know more now. We know that scare tactics don't work. Have any of you worked with anything that is now considered a scare factor? If you did, could you type some of those examples in the chat? I've given the examples of things like the Grim Reaper and mock car crashes. We know that those don't work. Any examples that you have worked with that might now be considered scare factors? How about the Scared Straight programs? Anybody ever work with those? We used to take our youth through examples of what it was like to be in a prison. We know those are no longer effective. Okay, let's go on to the next slide. Thank you. This is what we refer to as our continuum of care, or to abbreviate it like we have a habit of doing so much in our profession, it's your COC. As I told you, we've recently added promotion. We've got to promote what we're doing. The continuum of care starts with prevention, moves through treatment, and goes on through recovery and maintenance. Now, with prevention, we have different sectors. We have universal, selective, and indicated. When we look at the treatment part, you can see there's identification, standard treatment. Then with recovery, there's compliance with long-term treatment. And then there's aftercare, including rehabilitation. Well, because this one's on prevention, we're going to talk a few minutes on universal, selective, and indicated. Okay, when we first started doing, and we still are doing in West Virginia, universal programs. Those are your broad category. Everybody. I like to think of it as everybody in the universe. And they're designed to reach entire groups without pinpointing any other particular groups. Well, now with Partnerships for Success and other programs, we work with what's called selective and indicated. And your selective programs and practices, as you can see, they target individuals or groups who experience greater risk factors. You all gave me some risk factors, and that's what we look at with selective programs. Indicated programs target individuals who show early signs of substance misuse that have not yet been diagnosed. Now remember, we're talking about prevention. Jennifer put in our chat about this is your brain on drugs. And basically, I don't think that was a scare tactic. But what we do know from that and the different research we've had afterwards, it did not reach the target population. The kids didn't care about this is your brain on drugs, but their parents did. So sometimes we do an initiative and it doesn't affect the target population, but it does affect another population that might be viewing it. So thank you, Jennifer, for your example that you gave us. Okay, now when we work with universal programs, as I told you, those are programs that deal with the broader population. When we work with selective, we're a little bit more in depth, and selective programs target individuals at greater risk, but perhaps have fewer protective factors. So we want to build in those protective factors. When we work with indicated programs, we might work with youth where we do problem identification and referral, because in prevention, we do not diagnose, we do not treat, we do not work with recovery. There is relapse prevention, but that is not something that we do with our particular programs with block grant and partnerships for success. What you have now, you have some strategies where you might want to get some resources. We have SAMHSA and blueprints. And if you go on one of these sites, it will list some programs that we do use. Okay, I'm going to talk about Partnerships for Success because that's the grant that I work with. And I see Cheryl is on here, and Cheryl is one of our coordinators. So Cheryl, if you want to add anything, please feel free to put it in the chat. Now with Partnerships for Success, we build upon our existing prevention networks and partnerships. We're all in this together. If I were to ask you how many of you do treatment, prevention, excuse me, and I want you to think about that for a few moments. How many of you feel like you practice prevention in your particular focus that you're working in? Think about that and we'll come back to that. Now with Partnerships for Success, and we refer to that as our PFS grant, we intend to prevent and reduce underage drinking, IV drug use, and marijuana use, but we have a very specific population of focus. We work with 9 to 20-year-olds statewide with the PFS grant. We assess individuals who are at higher risk, as I told you. Universal is your general population, like your classrooms, like your community programs. Those are universal, and there are particular evidence-based programs geared towards that. With PFS, we work with selective and indicated. We also work with the WVCIA, which Tim works with WVCIA, who's in our group, to address issues with college students. And yes, Brandon, recovery support and prevention do go hand in hand on a collegiate level. That's why we're in this together. Cheryl, as you are in this particular workshop, is there anything that you want to say about working with selective and indicated students? What your experience may be? Okay, and while she's giving that some thought, Tim, is there anything you can share with us about working with the college population in WVCIA? You've been very active with your programs at Glenville. What are some things that you do with WVCIA that you feel are helpful for your students? Okay, well, they're thinking of that, hopefully. What I can share with you, Tim has added that freshman orientation materials. Tim does a very good job with something called TIPS, was training for intervention procedures, which works with, maybe he does it with his freshman students during freshman orientation, talking to them about issues with underage drinking and being on a college campus. Okay. Thank you. Next slide, please. With Partnerships for Success, I shared with you that we do selective and indicated evidence-based program. Now, we have 3 programs because this is still new in our state. We're halfway through our 5-year grant. We have found 3 programs that are implemented through PFS funding. One is called Positive Action. It's a school-based social emotional learning programs for students in elementary and middle schools. And the goal is to increase positive behavior while you're reducing negative behavior. We go on to life skills, which again is classroom-based, and then ripple effects, which is more working on a trauma-informed level. I want to go back to Cheryl. She did share with us in her work with Partnerships for Success that it's very rewarding to be able to work with the higher risk youth, especially with COVID. And we're entering a time with COVID where, to me, everybody has been affected, not just our students, but our teachers and our adults working with our young people as well. Life is different. So while somebody may have been spared from direct trauma, we all work with secondhand trauma. These are the 3 programs which we've identified for us to use in West Virginia for Partnerships for Success. And if anybody listened to the after-school programs presented earlier, they are doing positive action and life skills on a community base as well, not just in the schools. And Cheryl shares with us that she's used life skills and she's seen the increase in the scores from the pre to the post. When we do our evidence-based trainings, we do a pre-test, which measures the level going in, and then once a student or group has completed the program, we do a post-test to see if we've had any increase perhaps in perception of harm or an increase in knowledge. And Cheryl is sharing with us the life skills show some very promising and encouraging results. Thank you, Cheryl. I appreciate that. Next slide, please. When we talk about prevention strategies, there are 6 that we work most frequently with. Information dissemination, whereas where you might go to a health fair and somebody's giving out brochures, there's very little two-way communication. You're simply getting the information. With education, there's two-way. It's usually someone giving the information and then somebody receiving information. Alternatives are those things which we can provide through our funding, where maybe we have an event where it's a tobacco-free and alcohol-free party for kids to come to, particularly maybe like on New Year's Eve, where they know if they go out with their friends, there might be some drinking, but they don't want to be involved with that. So we offer some sites where we have alternative activities. Problem identification and referral. As I mentioned to you earlier, we in prevention do not do treatment or recovery. But if we are working with someone that we think might need some resources, we approach them or their parents about, perhaps if you have this problem, I'm going to like to give you some resources. So we do a lot of resourcing where you have that warm handoff to somebody that might be able to help or provide more information about treatment and recovery. Community-based processes. With prevention, we don't just go into the schools. People think prevention is you go into a classroom, you do your prevention program, and that's it. No, we work year-round. There's no downtime for prevention. We work with community programs as well, after-school programs, community gardens, boys club, girls club, local YMCAs and YWCAs. With environmental strategies, we work with policies and trying to change the environment to make it a more positive place for us in West Virginia. Thank you. Next slide, please. We also work through what's called a social ecological model for prevention. And that's some big wording for something that we do that means nothing about us without us. If you look at that, we know the term no man is an island, and that's very true. First of all, we have an individual. That person has unique knowledge, skills, abilities, values, and experiences. That individual also has relationships and those who are closest in your circle. Well, those folks also live in a community. That's the setting in which the relationship occurs. And then we have societal, which talks to us about our determinants of health. Thank you. Next slide, please. In working with our social ecological model for prevention, with the individual, we talk about adolescent substance use, constitutional factors, early and persistent antisocial behavior, early initiation of substance use, then internalizing behaviors such as depression, anxiety, or social withdrawal. You'll notice with individual, we talk about early concerns. Thank you. We move on to relationships. And in relationships, we can see where we might have family management problems, a family history of substance use, family conflict, favorable parental involvement, and friends who engage. So you see about the relationships, individual is about me, relationships is about we. Thank you. We move on to where it goes into community of school. That could be college attendance, school attendance, the environment. It can be fraternity and sorority membership. And through that, you may have academic failure or lack of commitment to even going to school. That's going to take us to our next slide, where we talk about availability of substances, your laws and your norms favoring substance use, firearms, and crime, and maybe your income and parental education. So it kicks it up a notch and goes out a step further on that slide that we showed. I'd like to talk next about vulnerable population groups. Now, with vulnerable population groups, we have varied groups. We may have somebody that's in a sexual minority that's young adults. We know that they're more likely than their heterosexual youth to experience stigma. And stigma is a big thing right now that we're trying to work with in breaking the stigma. They may experience discrimination and even violence. And we know that young adults who are sexual minorities that are at increased risk for behavioral health issues and substance abuse, sometimes trying to self-medicate and maybe get away from the pain that they're experiencing. Our next slide tells us that young adults who are homeless, and this is increasing as well. We have a lot of young people in West Virginia are homeless. Perhaps that comes under the definition of not living with their family of origin. Maybe they're living with grandparents and they don't see themselves as being homeless, but they're not with their family of origin. We know that the substance use among those adults is higher than that of peers who are not homeless. We know their social networks, the economic factors, their more negative expectations about the future are associated with higher levels of substance use as well. We know that polysubstance use, which means using more than one substance at a time, such as maybe tobacco and alcohol, it's more common among young adults experiencing homelessness. And those who use substances are more likely to have co-occurring, which means two at one time, mental health disorders such as depression, anxiety, and conduct disorders, along with the substance use disorders. With the vulnerable population groups, we know that young people who are involved in the juvenile justice system have substantially higher rates of substance use disorders than their counterparts. You know, young offenders are more likely to experience traumatic adverse childhood experiences. And if they're not addressed early, we know that the risk for recidivism, which means occurring again, and substance use increases into young adulthood. Okay, young adults who misuse substances and or develop substance use disorders are likely to struggle to attain traditional adult roles and responsibilities. They might have problems forming and maintaining healthy relationships. They may have issues getting that job and then holding that job. Substance misuse is also associated with more immediate repercussions. College students might report hangovers, nausea, and vomiting due to drinking. They might not even be able to attend class. If you can't attend class, then you can't complete that particular course. Is there anything that you all might like to note in working with vulnerable populations? Are you seeing more vulnerable populations in your practice or in your teaching? Would anybody like to put anything in the chat about vulnerable populations? I personally am seeing an increase in vulnerable populations, which the earlier we can identify those particular populations, we can work with them. I used to work at an adjudicated facility for young adults, and I always felt like there was hope, because if we can identify the issues, we can help with the hope and the referral to different resources so we can lower that recidivism rate. Okay. Well, I would like to go on to something we call the Strategic Prevention Framework, which we refer to as the SPF. Now, this is what we work with in prevention. It's SAMHSA's Strategic Prevention Framework, and it's the planning process for preventing substance use and misuse. And I want you to notice it's not linear. It doesn't have a beginning. It doesn't have an end. Okay? Okay, we just got something in the chat that says participants are blocked from sharing their video and audio. Okay, thank you. Now with the Strategic Prevention Framework, it's circular, as I started to tell you. There are 5 basic steps. It starts with A, which is the beginning letter of the alphabet, so that's a good cue for us. Anytime you want to start working with a program, you assess it. You work with assessment, you go to capacity, planning, implement, and evaluate. Sustainability and cultural competency are throughout the entire program. So we're going to talk about each one of those a little further. If we could go on to the next slide, please. We know with assessment, that's our starting point. As I told you, it's circular rather than linear. There's no beginning, there's no end. Sometimes you go backwards in order to get to where you need to go forward. Assessment is reliant on data, it's data-driven, and it encourages a team approach. It helps planners gather and use data to guide all the prevention's decisions. So assessment is our beginning. Thank you. If we can go on now to capacity. When you're working with capacity, what you look at basically is builds on resources and readiness to address prevention needs. What do you have to work with? And then you go on to planning. Well, what can we do and how should we do it? You start your plan. You find out who works with what to address the needs and how well to do it. It moves to implementation, where you're going to actually implement or deliver the evidence-based programs. How can we put that plan into action? And then you go to evaluation. You evaluate. You might even want to evaluate before you get to that point, because you've got to know if it's working. If something's not working, do you want to keep doing it? No. Even if your funder has given you X amount of dollars to do the plan, and when you're getting there and you see it's not working, don't keep spending that funding for something that's not working. You go back and you talk to your funder to see how you might be able to do corrective action to get it to work. Thank you. So I mentioned to you that cultural competence and sustainability need to be applied through every one of those 5 steps, starting with assessment. Cultural competence is the ability of an individual or an organization to understand what is competent within that culture. You know, many years ago when I attended my first training on the SPF, we were asked what cultures we belonged to. Well, at the time I was a single parent, and I didn't realize that was my culture till the presenter pointed out, asking me questions. I said, I'm a single parent. They said, that is your culture. And I said, well, why is that my culture? my child still is getting the best for me. And the response was because my frame of reference comes from being a one-parent household instead of a two-parent household. So my culture that I raised my child in was that of a single parent. We also know it's the ability of an individual or an organization to interact effectively with people who have different values, lifestyles, and traditions based on their distinctive, not only heritage, but their social relationships. Now, through this process, we always want to maintain sustainability. We've got to keep these programs going. What if the funding isn't there next year? Through each section of the SPIF and through every program you work with, you want to build capacity and increase skills of not just the adults, but even the youth, because they are going to keep the prevention process going. They're going to keep its sustainability. So remember, cultural competence and sustainability need to be present on every level that you're doing prevention. Now, with competent cultural competence, I'd like to go into it a little further because it's really, really important. And SAMHSA has identified the following principles for prevention professionals. You always include your target population. And actually, we now prefer to use the term population of focus because target, what do you use a target for? You shoot at it, you try to hit the bullseye. That was a term that we know now better in working through our process. We use population of focus. The community needs to define itself. You don't go in there and define any community, especially if you're not a member of that community. Nothing about us without us. You want to stress the importance of relevant, culturally appropriate prevention approaches. We live in an Appalachian culture. For a long time, I live in a county that's more northern. And for some reason, where I live, the people assimilate more with Pittsburgh rather than southern West Virginia. But that is my population, my culture. I was also told I live in the Appalachian culture. Now, personally, I come from an Italian American background, so that's the culture that I assimilate with. But upon more thought, yes, all of us come from an Appalachian culture. And when I do my prevention practice, I need to understand that in the Appalachian culture, when I provide anything in writing, I don't want to go higher than maybe a fifth or sixth grade reading level because we still have folks in our practice that perhaps don't have a higher level of reading ability. I need to remember my Appalachian culture where by tradition, the Appalachian folk are storytellers. So rather than for me to get in there and talk to people, we want to share stories because that's how we share our memories and our traditions. Anytime I'm doing any kind of evaluation, I want to use culturally competent evaluators. I want to promote cultural competence among my staff and reflecting communities they serve. You know, when looking at our programs that we implement, we look at programs maybe that were researched in California and proven to be effective there or New York. Is that going to work as well as something that was for the Appalachian culture and the research was done within the Appalachian culture? No, we want to use culturally relevant programs. Thank you. Next slide. With sustainability, we know that prevention takes time, something I heard from the beginning and I'm still trying to understand it 30 years later and keep it in mind. It's a process, not an event. You know, prevention is hard to evaluate because if you're doing treatment and you're working with a person or a group, you chart change and you chart success into maybe the recovery stage. With prevention, you're working with something that has not yet occurred and you want to delay the onset of first use. It's a little more difficult to evaluate prevention. So I have to understand it takes time. Substance misuse problems and priorities change. We say that, and I'll tell you, I've been doing this for over 30 years, and everything old is new again. At one time, underage drinking was our problem. Well, it went from underage drinking to different issues with tobacco use. It's gone from tobacco use to we're working with vapes now, but we're finding that youth today are going back to alcohol because it's easily acceptable. You know, how many times I can't tell you, a parent will say, oh, it's just alcohol. It's nothing. It's not heroin. They're not doing opiates. It's just alcohol. Just alcohol is becoming our number one problem with youth again because they can get it and it's more culturally acceptable as a rite of passage. We know through sustainability we have to have successful implementation of the strategic prevention framework. The strategic prevention framework was that circular process that we just went over with sustainability and cultural competence on every single level. We know that sustainability is recognized by public health funders. We know it's a process that can help planners establish a shared language across health issues. And we know it's disciplines, various disciplines. So it's interdisciplinary partnership. You're on here from different disciplines. We're in this together. We want to work together. Next slide, please. With protective factors, I asked you to share those earlier. I'm reinforcing them again because they are so, so, so important. And here's a few if you haven't already thought of these or worked these. And then next, I believe we have risk factors. Again, that's just to show you all some of the common risk factors. Academic factor failure is a very big risk factor. When kids are doing well, they don't want to go to school. They don't want to be made fun of. And nobody likes to work where there's failure, not even youth. Next slide, please. Another program that we work with, which is not my area of expertise, but Tiffany Pittman is on here, and she works with expanded school mental health. So Tiffany, anytime you want to chime in, please type in the chat. ESMH refers to expanded school mental health programs. They are done on school sites. They emphasize services and supports of all students. It's the critical link between mental health and academic success. You see, we use that success. It's asset-based. We have meaningful involvement. They use evidence-based and best practices and programs and continuous quality improvement. And Tiffany does tell us she's glad to be here. Tiffany, what can you share with us about expanded school mental health? And I'll have the next slide up so you can see what we're going to talk about next briefly. This is one of Tiffany's favorite slides because she shared it with me. So thank you, Tiffany. What are some programs, Tiffany? Can you share with us any of the programs that you do with the expanded school mental health? Okay, she tells us it's growing across the state in this comprehensive 3-tier model. You can see there's the universal. Remember, I told you universal is everyone, targeted and intensive. They expanded school mental health uses a little different verbiage than what we use the selective and indicated. And she said tier 1, they use second step, caring school communities, and Too Good for Drugs. With tier 2, they use coping cat, resilience builder, life skills, and ripple effects. And if you recall earlier, I told you with Partnerships for Success, we use life skills and ripple effects as well. Tiffany shares with us that tier 3 is therapy, which is clinical mental health therapy. So you can see when prevention is working with expanded school mental health, we're working together to suit the needs of the student because we want to be person-centered. Those are examples for each tier, but there are probably over 100 evidence-based practices, programs in use with expanded school mental health. If you've not heard of expanded school mental health, please try to connect with Tiffany Pittman. And Tiffany is on, and she's in this program today. So try to network her during the network opportunity. Next slide, please. Here are some valuable prevention resources. We work with Help and Hope. We work with Help for WV, Stigma-Free WV, and through the Bureau for Behavioral Health. If you click onto any of these sites, you're going to find a lot of the information that I shared with you today. Does anybody have a question before we go any further? Or thoughts? How do you feel about this with prevention in West Virginia? Are they things that you've heard of? We in prevention want you to know we're there to work on a universal level. If you have your own child or you want to know what's available in school, in West Virginia, it is a legislative mandate. Each school is to provide some type of prevention. If you are teaching and you want to know what some of those options are and how you might be able to utilize funding, please click on one of these sites and it'll get you somebody to get in touch with. If you have a child and you want them to be involved in a community program, please let us know as well. Could you go to the next slide, please? These are the 6 regions in West Virginia. So if you click on the Help and Hope site, you can find this particular picture and you click on your county and it shows you what region you're in and who you contact with. Next slide, please. I have included at the end of my slide, which you'll have access to this PowerPoint presentation, your particular counties in the state. It tells you which region you're in, who your prevention lead is in. This is region 1 and 2. If you go further, you're going to have 3 and 4. And you're going to have 5 and 6. And what I want you to notice, I've listed the regions, the counties, the prevention lead organization, and that name of the person that you want to contact with that's in charge of the Partnership for Success grant, and who your PFS coordinators are. So at the end of my presentation, you've got this wonderful resource that'll help let you know exactly who you need to reach for services in your county. And the next slide, please. These are the references from which I got my information. And I believe the last slide, that's me. This is my contact information. I gave you my email. That is my cell number and the website. So please don't hesitate if you want more information or you want to get in touch with Tiffany Pittman, who does expanded school mental health, or one of the PFS coordinators, such as Cheryl Janice, who was in this workshop. Give me a call or look us up on the website and we'll be glad to answer your questions or help you implement any programs that you might want to have implemented. Any thoughts? Did this help with prevention? Okay. And Jenny Lancaster has graciously listed the links that I mentioned in the presentation. Well, thank you for being here today, and thank you for being at the Student Success Summit. There are so many opportunities for all of us to learn about different populations of focus, different questions, and thank you as well for being with me today. It's always a pleasure. Please let me know if there's any service I can provide to you. Have a wonderful day.
Thank you, Joanne. We appreciate all the information that you provided. As always, very helpful. If anyone does have any questions, you can reach out now in the chat box, or as Joanne said, she's given you her contact information, and we will have slides and so forth available after the conference. So we appreciate you guys being here, and have a great rest of the conference. And thank you so much, Joanne, for your wonderful presentation.
Thank you.